Okay, so we called a charge nurse meeting this morning to talk about changes that we're going through with our county positivity rate. It was at 26.4. It is now down to 16.7. But because it is still very high in our county, we have done a few changes, like the quarantining of residents when they have an outing for any time out of the facility. When a resident goes out, they will be quarantined for 7 days, and then on the 8th day, you can test them and release them from quarantine as long as they're negative or not symptomatic. They can have visits during that time if it is a porch visit or if it is a compassionate care visit that has been approved by Sarah or I, or Alexis is fine, whoever's on call could handle that situation too, to make sure that it's an appropriate compassionate care situation. So those are the main things. Quarantine just means though that we are monitoring, increasing our monitoring for symptoms and, just observing, making sure they're not symptomatic from the outing. And it's completely different than an isolation. Isolation is we're gowning up, we're gloving up, we're wearing all of our PPE to go into that patient's room. When we are in quarantine, I think there is a little, maybe not confusion, but everyone, when we had the whole lockdown, everybody was staying in their rooms, everyone, on the communication that we put out, we said there's no communal dining and no communal activities. But that did not say everybody has to stay in their room at all times, and because people go stir crazy sitting in their room, I wouldn't want to sit there 24 hours a day looking at the same wall. So just don't let them congregate, but they can come out and go for a walk or go get a cup of coffee or, whatever those kind of things are. Just, just no congregation together in groups while we're in that monitoring phase. If someone is on isolation, there should be no visits unless it's a compassionate care visit. They should remain in their rooms, just continue the same monitoring that we're doing. We do have one patient that was a new admit that is on isolation. We have since she's been admitted that there were positive patients at her home that she came from, so we need to take that very seriously and do thorough monitoring and protecting ourselves and other residents by wearing your PPE, okay, with that resident in particular. Some things we've learned from our recent little outbreak that we had with our 3 positive patients, that in itself led to part of this quarantine, because we know that our first lady was exposed at a ice cream social in the community. So that's where we went to, okay, when somebody goes out, they're gonna have a quarantine for that 7 days for monitoring to try to, if they had an exposure, to limit that exposure within the building, okay? So then by her exposure, then her roommate also became exposed. I think from this point forward, just as it doesn't say it in the guidelines or the regulations, but just to be best practice, I think when we know a resident has an exposure, then we need to go ahead and move that roommate out to a room by themselves if possible. And I know that's not always possible because of our census and room situation, but try to separate them as soon as we learn about an exposure to try to just limit the exposure for the other roommate and maybe keep them from getting COVID. The third person we know, or the only traceable thing that we can come up with, is that it was a equipment sharing situation between the roommate that was removed and was in a quarantine situation and a man that was across the hallway or down the hallway. They were sharing a phone, our portable phone. And we've since learned that not everyone was disinfecting or cleaning the phone in between that passing back and forth. So as far as we can trace or contact, that's probably where the third person got the COVID virus from. So that being said, we have a new tracking system for our phone to log out where it is, who's had it last, and make sure that it's a little checkbox where you make sure it's disinfected before you take it to the next person. And I think we were gonna get some Lysol even to spray, because you know how it gets down on those little crevices of the speaker on the phone, you know, and let it set for a few minutes, make sure it's dry before you take it on to the next person. So we're not spreading anything like that. Also with vital signs equipment, be very careful about that you're cleaning and doing that in between patients.
And when we have the COVID unit like we did recently, where there's the complete isolation of a few people, that the vital sign equipment stays inside that unit, that we're not dragging stuff back and forth. We need to keep things separated. We have enough stuff for that.
The manual stays back there,
Yes.
equipment.
Or there's another we do have an extra tower.
The old
somewhere
tower
that
or
can
the
stay
new
back
tower
there.
you can use, you know, one or the other in that area.
I did take the tower back there because when I went in to use the manual blood pressure cuff, it was like starting on 20 and
Oh.
not,
Sure.
so that's why, so we,
Sure.
no, we need to make sure we have some,
Right. So if in that
Properly
instance,
working equipment.
just make sure when it comes back out then that we are thoroughly wiping everything down and letting it dry good is all.
Yeah, just remember that it has to have that certain exposure time to kill the virus, so make sure you're laying it completely dry before you take it to the next place or wherever you're gonna go with it. Back on the porch visits for a moment, make sure when those residents in quarantine are going to a porch visit, that you're having them do good hand hygiene before they're going out, that they're wearing their mask while they're going up the hallway, and taking them to a porch that has the plexiglass in place. And I know a lot of families are coming around to the side of that plexiglass, and that's not ideal, but if they are, set the resident back at least where they have that 6-foot social distance. Okay, so don't put them right up to the rail, you know, face to face, because we are monitoring them for symptoms and we don't want it to spread to a family member even, or vice versa. So, and also do good hand hygiene when they're coming back inside, okay? Because of our little outbreak too, we had a CMS, what would you call it? CMS
referral.
referred us to HQIN, which is a branch, I guess, of CMS for that we needed to come up with an action plan. They say it's not disciplinary, it is not like a plan of correction, but yet we have been focused on, because we are in a hot area or of a COVID spread, and we did have an outbreak in our home. So we had a telephone conference with a lady from HQIN this week. She is reviewing and determining what our best action plan and focus area is. So far, we probably are going to focus on mask use. So we are going to be very diligent about masking, making sure that your noses are covered, that you have your mask on at all times. If you're supposed to be wearing an N95, you've got your N95 on. If it's surgical mask, you've got the right kind of mask on. Doing a seal test when you clock in, make sure that you are, you know, tapering your firm area there. And if you can blow hard and feel air coming out of it, then it's not a good seal. They want us to make sure that we have good seals when we are wearing our mask. So therefore, none of this when you're walking down the hallway. And so that will be required we will have to come up with some kind of action plan and figure out a measurable goal. Like, we have 50% of people wearing masks now. Hopefully it's higher than that. That's just an example. And by the end of our action plan, we should have 90%, or, you know, we just have to have a measurable goal and show proof of what we did and how we got there. So it's very important that we focus on masking. I mean, we should be anyway, especially when we've had an outbreak, but, you know, we've saw people walking up and down the halls, whether they're coming in or clocking out or whatever, not wearing masks when they're in the building. Anytime you're in the building, you have to wear a mask, you know. So that's kind of going to be our focus. We have until, I think she said September 15th to get our action plan kind of submitted to CMS. It will be submitted to them. And the way I understand it, like, our state surveyors will be able to access that information and show that this is what we did and expect us to be following it. So it's not a plan of correction, but still it is very serious for us to have that referral to CMS. You know, it's not something we should take lightly, and we should really focus on it and address on it.
And honestly, just see this latest round as what it is. It was a mercy. We know it could have been worse. I think that there are a lot of good things that we've, because of our practice, from our history, a lot of good things that we were implementing really quickly. We've got the supplies, we've got the equipment, staff has been through this, so I kudos to all those staff, because obviously it's not ideal that it spread to that patient 3. We know, we believe we have a good root cause analysis for that, but obviously it could have been far worse, right? And so just again, we've talked about this, it is not in these 3 parties' nature to be dictators. It's not in our nature to be hard asses. When it comes to masking, it is now a responsibility of everyone, particularly the people in this room, particularly people in leadership, to be that hard ass. Masking is not optional. Proper masking is not optional in this building. So just staying diligent. No one is perfect. We all are a little mask fatigued, COVID fatigued, but just staying on top of that, because there are consequences. Because of that, we are doing extra work on top of the extra work that we're already doing. And without a doubt, this is going to be reviewed by state surveyors. And keep in mind, whether they're in the building or not, they know that we have an issue with masking. One witnessed improper masking can result in an IJ. That's immediate jeopardy. That's serious.
That's money.
Yes, ma'am.
A lot.
Yes, ma'am. Money that we don't have to spend, quite frankly.
Fines, it comes
So,
with fines, and you
yes.
can also go with you can't admit any new Medicare
There's a
patients.
moratorium on admissions. There's a moratorium on Medicaid and Medicare funding.
Yeah,
It's
so-
serious, and we're already at a
detrimental.
census of 41.
And if we
42.
had an outbreak associated with that, I mean, they could really shut down the home if they wanted to until things were corrected. So it is very serious. We have to take it seriously.
Any questions? You know, again, we get the frustration with things being fluid and changing. We get that. We feel the same frustration. I was sharing earlier, this is the guidance that we've had just since January. And we have to sort of move within what they've given us. And then as Kathy indicated, you know, with the dividing of the 2 people, it wasn't in the guidance to do that, but we think now probably we're going to do that. It's not in the guidance that we quarantine for 7 days following an outside visit, but that's been our fear since this started, that was how it was going to get in the building. So we have to react to what's going on currently and try to respond appropriately. If you have questions, please, please, please reach out and ask. If it doesn't make sense, ask, because maybe it's something we missed, or maybe it's something we haven't communicated appropriately. So just don't be afraid to ask, and then help us spread that information. I think one good thing that came out of it, because we try to look back and learn. So Kathy's got some outlines that we've done over different scenarios, and we're gonna try to be good about, as things shift or move, taking those and getting those right out to the nurses, so that you guys know and you're aware of what the new latest and greatest is and how that's changed. But do you have any questions? Please ask questions.
Is there anything new that needs to go on our screening sheets?
Nothing
As far
that-
as the Delta, and any symptoms or anything that we need to add on there? They say
No,
almost anything new for you can be a symptom.
Exactly. So that just comes with our monitoring and knowing our patients and knowing that this is not a normal symptom from them. I think our sheets are pretty thorough because it covers headaches, nausea, vomiting, have you had a fever? And, it's not so much always a respiratory issue. We know that some of our people are having nausea and vomiting, or some, but employees have, that's been their main sign. So I think just knowing our patients and knowing that, hey, this is abnormal and we need to keep a close eye on what's going on. If somebody is symptomatic, don't be afraid, come on up and test them, because I'd rather be safe than sorry, get a POC and just see, and so just when something's off, basically, that's what we're watching for.
I think we do. Let's just talk a little bit about the new mandate that's coming for mask mandating. Know this, that we've been putting this off at least the last 3 months. We've had it discussed as a topic at our board meeting, postponing masking mandates. Well, now it's going to be beyond our control. The president is now using our Medicaid and Medicare funding.
Vaccine.
I'm sorry.
Vaccine mandate.
I
Yes.
did. I'm sorry.
Yeah.
That's
Thank you.
okay.
So we'll just talk briefly about that. We have no guidance yet The information that we received yesterday was that we would be getting the guidance sometime in September that's going to force our hand and require a vaccine mandate. What that is, what it's going to look like, I don't think anybody knows because they don't even know yet. What they've put out for previous implementations is going to be different than what we've got, without a doubt, because they allowed for some gray area with federal employees meeting criteria that we're already meeting. So we know it's going to be in addition to what we're already used to doing. Obviously, I think we all believe that it should be an individual choice, and if we can help you maneuver that, we will do that. But at the end of the day, we have to follow guidelines because we can't afford to operate without Medicare or Medicaid funding. So just work with us and know that we don't like it either. And do I personally think that it's a good thing? Yes, I do. I don't think it makes our residents any safer, but I think it makes our staff safer. Now that we've seen firsthand, it's one thing to read statistics. It's one thing to have scientists say this is what the vaccine's going to do. And it's a whole nother thing to see it up close and personal like we have recently. The 3 residents that we had that contracted the virus this last round were all vaccinated. And I think we all agree, I think everybody here was with us last November. It was a very different reaction than what we saw last November from our residents. And so that gives me some peace in believing and trusting that it is doing what it's supposed to do. Do you have anything to add on that?
My thing is if you've got the antibodies, if you're getting tested, you have the antibodies, that's supposed to be just like having the vaccine, then we shouldn't have to have the vaccine.
That was the argument, and you can ask these ladies, that's the argument that I made with HQIN on Wednesday. She did not disagree with that. Here's the dilemma that we run into. At what point are your antibodies going to waver and make you susceptible? Unless you're checking those regularly, we may not know. The other thing is you've got antibodies to the old virus, right? And we know that it's changing and morphing and all of that, which is the whole reason we're going to have a booster. Just like with the flu vaccine, you've got to go after what's going on now. So the antibodies that you have may or may not be sufficient to fight the new variant. In theory, once everyone's received their full vaccinations and we go through that booster, it would help you combat that. But again, that was the same argument that I had, and that was the rebuttal that I got from them. So, and you recognize that, right? Not everyone is going to test their antibodies on a regular basis.
Right.
And so to take this already incredible workload that we're doing, just doing the testing, and then you add antibody testing on top of that, it's just easier, safer, at least from a broader perspective, that everyone just get vaccinated that can get vaccinated. So, I fought it, guys. I did. I mean, okay. Anything else?